pain differently. It is considered acute pain, and again, we're going to try to check with the mom and ask what their preference is for pain management. So when we think about labor pain, again, we think about visceral and somatic. So again, the first stage, again, that uterus is contracting. We have a decreased blood supply, decreased oxygen. We get pain from stretching and dilation. We get pressure on the perineum, the cervix, the urethra, and the rectum from the pain of the baby passing. And then again, we get the uterus clamping down after birth. So again, we get pain from that as well. Thinking back to the very basic, pain threshold, right? So again, everybody's pain threshold is different. So, you're doing good, and all of a sudden, like, boom, that pain hit, right? So again, everyone's is different, and so we want to make sure that we understand. Sometimes it can vary based on culture, if they're very stoic, and how they express their pain. So thinking about factors, again, that gait theory of pain that you learned probably way back in fundamentals, right? The sensation of pain transmitting along the periphery and that ascending nerve pathway. So we can use different things like distraction, massage, heat and cold, breathing, having a pick a focal point to focus on to try to help that. But again, the rate of their dilation, the strength of their contraction, the size of the fetus, their culture, their labor support, their previous experience in childbirth, as well as their preparation is all going to affect their pain. They can use non-pharmacological methods. They're safe. There's very few adverse effects to them. Inexpensive. They get a sense of control then over their childbirth. But some of them do require practice doing. So again, if they're going to think of like guided reflection and things like that. All right. NCLEX practice in educating clients about non-pharmat alternatives. Which topic could you delegate to an experienced LPN who will function under your continued support and supervision? Therapeutic touch, heat and cold, meditation, or TENS?
Use of heat and cold.
Yeah, use of heat and cold is safe. It has predictable outcomes. Therapeutic touch would require special training. Meditation, believe it or not, is considered a spiritual belief, and so they don't necessarily talk about that. And then TENS is usually performed by PT. All right, and then we have pharmacological pain relief. Okay, so this is when we're going to have our pharmacological as well as non-pharmacological, right? A lot of times you use them combined together to help with that birthing experience. Nitrous oxide, again, we joked about it a little bit in lab, but we see it used a lot in Europe. It's safe for moms, it's safe for babies. It takes about 50 seconds to take effect, but I know Lexi said that she was seeing it being used at other hospitals too, so maybe we'll see more of it used here. We see, again, a combination of pharm and non-pharm for better relief. All right, first one, spinal anesthesia or spinal block, you'll hear it called. This is anesthesia with or without an opioid. But again, when we look at the location, and that's why again I try to show the picture here, this medication gets injected between the 3rd, 4th, or 5th lumbar subarachnoid space. So it's in that subarachnoid space. So with this, we see a lot of moms have hypotension that occurs when this happens. So in order to prevent that, you'll see a lot of these moms, what do we give them before they get their epidural? So it's an L&D. What do you get?
Oh, that's like a liter.
Yeah, so they get a fluid bolus, right? So they give them LR, give them a liter of fluid to try to prevent that hypotension from occurring. Again, we evaluate that once it's in there. Again, the hypotension causes from the vasodilation and pulling of the blood in the extremity. So, one of the things that they can get is an unfortunate side effect, and I experienced this myself, but a spinal headache. So if they go too far, right, we want to get into that subarachnoid space, but if someone has tight spaces, or if they're new, in my case, my guy was a new resident, and I didn't know that, but if they go if they go too far, right, they can puncture through. So a post-dural puncture headache or spinal headache, you'll hear it called. So with this, you have a terrible headache, worse than any migraine. if you're sitting up, if you're standing, any kind of compression on the spinal cord, right? If you're lying flat in bed, nothing else going on, you don't have the headache.
If someone has a previous spinal cord injury, are they still able to get this?
That I'm not sure on. So with this, again, they're puncturing the dura mater, so again, that's why we have this CSF leaking. So in order to fix this, they can do a patch. So what they do is they try to go into that same space again and patch it with the blood, so like a scab would form over that hole so that the CSF isn't leaking. So you get an improvement in that headache, you get improvement in that sensitivity to light, but as they told me when they gave me that as an option, which I didn't select, they have the risk of repuncturing you again if they don't get in the right space again. So I just said, that's okay, I'll wait it out, wait my 2 weeks, and I left the sunglasses on and tried to lay down flat as best as I could. So again, just making sure that we are aware of that. If they complain of headache, it's not, it could be an epidural too. All right, epidural. So again, in the epidurals, the injection occurs now in the 4th and 5th lumbar vertebrae. So again, they go into the epidural space. Again, a patient that maybe is obese may be harder to maintain the position needed for that landmark. And again, with this, women can still push. Again, we don't want them to be lying flat on their back, again, for the compression of the vena cava, but again, just like with the other one, we're gonna bolus them beforehand. A lot of them experience itching, so that's a common side effect of this. But again, sometimes it can slow down the labor, sometimes it can cause them to result in a cesarean delivery as well. And then some, you'll see they get what's called a combined spinal and epidural, or what they call a walking epidural. Again, that analgesia is injected into the subarachnoid spinal space, and then the epidural is given. So you can see that based on this picture here. So they only need small amounts of med for this. This is just a picture to try to help you see, again, if someone is going to be given a vaginal birth, where they're numb to, if they're given a cesarean birth. I know, like when I was having mine, they took a little stick, broke it in half, and started poking and say, "Can you feel this? Can you feel this?" Right? Because they want to make sure that you're numb as well. General anesthesia, again, infrequently given. It's not like it's given for elective cesarean sections, but again, if we needed to resuscitate or have a birth immediately, we can do that. All right, labor and birth process. So when we think about the 5 keys of labor, so again, looking at this is passenger, passageway, powers, position, and psychologic, right? So when we think about the passenger, that's the baby, right? That fetus that's gonna be coming out, right? When we think about the passageway, that's our birth canal. The powers would be the contractions, right? The ability to push that baby out. So looking at the passenger, our first P, again, we're looking at the size of the baby's head. If baby's head's too large to fit, there's nothing that you can do to get it to fit, right? So again, sometimes that's why they result in a C-section. We also want to look at their presentation, right? The baby should be up and down, the same way with mom's spine. Mom's spine and baby's spine should be the same direction, right? And we want to make sure baby's head first. We don't want a breech baby, right? So again, we look at things like that. Just reflecting, thinking about your bones of your skull, again, just a reflection back to that. So you got your parietal, your temporal, your frontal, and your occipital. And then you get the suture lines. And I feel like this picture better kind of shows that to kind of remind you where everything is there. You'll see the fontanelles, again, for those of you who have felt the baby. So you have your interior fontanelle and your posterior fontanelle, again, diamond shape and triangle space, triangle shaped. So when we look at the fontanelles, the diamond shaped one on the top, that interior fontanelle, it usually closes about 18 months of age. So that one will stay open longer than the posterior one, the triangle shape, which usually closes about 6 to 8 weeks after birth. Both the sutures and the fontanelles are flexible, again, to accommodate that growing brain. Nothing is firmly united. Sometimes you'll see an overlap, again, of the of the sutures, and that can be called molding, and you'll see that referenced there. Sometimes baby have an abnormal head shape due to various factors during delivery, but their head should regain its normal shape about 3 days after birth. Again, thinking about the presentation or how that baby's presenting, 96% of all births, again, head first, right? So phallic. So we want to make sure that that baby's head first when it comes out. If babies breech or feet or bottom first, we don't want that, or the shoulder presentation as well. And so I have a couple pictures of that. So you can see here Frank's breech up there in the upper left-hand corner, where both feet are kind of tucked up and their bottom is presenting. You can have a footling, again, where one foot is kind of falling through and the other one is up. You can have complete breech, and then you can have a shoulder presentation where like so the shoulder's presenting. So we had a mom that was breeching when we were at Barberton one time, and the resident came in. He's like, okay, I just have to verify that the baby's still breeched before we do the C-section. He came in and he's looking with the ultrasound, and he was like maybe 5-10 minutes goes by. He goes, okay, yeah, the baby's breeched, but I think, but let me go get the doctor. And so he came back with the attending, and of course, but I thought, like, how could you not tell if it, like, I mean, you could clearly see a feet or head just first, like, but apparently he couldn't on his ultrasound. So again, when we think about the way the baby is presenting, even with that head first, right, it could be vertex presentation, it could be syncopate or brow, again, depending on the way that the head is presenting inside the pelvis. We also want to look at fetal lie. So again, that's the relation of the fetus spine to the mom's. Like I said, fetus spine and mom's spine should be the same direction, right? Up and down like that. We don't want baby to be lying across. You won't be tested on the test about this, but just if you ever see it, they'll look at the presenting parts in relation to mom's pelvis. So the first letter, if you'll see, like, and I have it on the next screen, it kind of makes more sense when you see the picture, but the first letter is the location, whether it's right or left. The middle letter is the presenting part, and then the third letter is the location, like whether it's anterior or posterior. So again, if you look, you'll see things like ROA, and that would stand for right occipital anterior, right? So again, you can see the example of the picture in relation to that. All right, it's important to understand stations. So that's the relationship of that fetal part in relation to the ischiospine. So I'm just going to pop forward real quick just to say, again, we have this imaginary line where these ischiospines are, okay? So again, thinking back to your anatomy. When we look at this, the ischiospines, if they're above the ischiospine, so again, remember that ischiospine is kind of like our zero, our starting point, right? If we're above the ischiospine, it's negative. So think it's negative, the baby's not coming out, it's not a good experience, right? If it's below the ischial-spine, so again, as we start to have the baby come out, again, +1, it would be under the ischial-spine, +2, +3, it's positive experience, baby's coming out, right? So again, when we look at this, engagement is, again, when station 0, that's the beginning of labor. And so again, when the baby's at like +4, +5, that usually means that birth is imminent. Powers, again, are uterine contractions. That's involuntary, right? So we can't just say, okay, uterus, go ahead and contract right now. That would be great if we could control it, right? But you can't. But you can voluntarily bear down and try to help and assist with that contraction as well. All right, another one that's big and important to understand, effacement and dilation, okay? So effacement is the shortening and thinning of the cervix during that first stage of labor. And we see this measured in percentages. So you'll see 20%, 30%, 40%, right? And then we see dilation. So that's the opening of that cervix. And again, expressed in centimeters. So 1 centimeter, 2 centimeters, 3 centimeters, okay? When they're fully dilated, as you remember, you probably saw the board when Ms. Costello showed you. But again, when you're fully dilated, you can no longer palpate the cervix, okay? So there's something called the Ferguson reflex. So that's when the fetus hits the perineal floor and causes this mechanical stretching of the cervix. So it causes a release of oxytocin, and then again, mom moves into wanting to push. So if you had a patient that they told you the patient was 4 centimeters, 40%, and -1, what would the 4 centimeters stand for? Dilation. What about the 40%? And then what about -1? Would that be above the ischial spines, 1 centimeter above? Good. All right, so again, this picture, I always feel like, and we'll do a little fun exercise next week with it, but I feel like this picture is nice to try to help you understand what is happening when that cervix is dilating and the effacement is happening. So you can see slowly as you move from picture A to picture D, how you can see how the baby's head descends and it's kind of drawn up and around that presenting part. Contractions, when we're looking at the contractions, again, just some definitions, the frequency, so the beginning of one to the beginning of the next. Obviously, the more frequent the contractions, the more likely we're gonna have a baby, right? Our duration is the length of that contraction, and then again, we look at those intensity or the strengths. And for those of you in L&D, it's always fun. You can always start to see like that top of that hill kind of going up. Oh, mom's getting ready to have it. Then the mom will feel it, and then they'll start to, you'll be screaming. But when we look about the process of labor, again, we have true labor, like it says here, when there's contractions with cervical change and fetal descent. Okay, so again, we get that to demonstrate when we truly have that. So sometimes moms will experience what they call lightning, or the baby kind of dropping into that pelvic area. And then sometimes they may start to have bloody show, again, looking at that. But again, we're gonna look at changes in their cervix as well as that dilation. All right, stages of labor. Whether it's for this class, next test, final, NCLEX loves stages of labor too. So the stages of labor just recently changed. There used to be 3 stages. So sometimes if you see in some older textbooks or maybe some testing, there used to be 3 stages, and they changed it to 2 stages about a year ago. But the first stage, okay, with the first stage of labor, there's 2 phases, okay? So when we think about the first stage of labor, this is from the start of when mom is having these contractions until she's fully dilated to 10 centimeters, okay? Now, within that, they break it out and say latent is 0 to 5 and active is 6 to 10. In the latent stage, again, that cervix is dilating, we have mild contractions. This could be hours to even days that someone is in latent or early part of their first stage of labor. You can have some moms go in for their, well checks, and they could be 2 centimeters dilated and sit that way for another week or 2, okay? So again, that early kind of latent phase. Then we have our active phase. Again, we're gonna have more stronger contractions, they're gonna be closer together, they're gonna average their dilation about 1 centimeter an hour, and it takes about an average of 4 to 8 hours in the active latent phase. In the second stage of labor, that's gonna be the period of time, okay, so we ended the first stage, mom was 10 centimeters dilated, right? So this is gonna be the pushing phase, and that is complete when the baby comes out, right? So the second stage is the pushing and delivery of the baby. So again, when that baby comes out, second stage is over. The third stage then is from when the baby comes out to when the placenta delivers. And usually that's within about 5 to 10 minutes, right? And for those of you that have been in L&D, you see that placenta comes out pretty quick. And then the fourth stage would be 2 hours postpartum. So after delivery, again, we're gonna be checking frequent vital signs, fundal heights, watching their bleeding, again, in that fourth stage. So again, 4 stages altogether. The only stage that has 2 phases is the first one, okay? All right, fetal heart rate, again, just remember, normal 110 to 160. Fetal circulation, again, they adapt to those contractions. And then again, their respiratory, clearing the lungs during the labor and the vaginal birth, fetal respiratory movements can increase during labor as well. All right, so now we're gonna go to your favorite part of the